Awesome. Dr. Browne, thank you for joining me. Glad to be working with you.
My pleasure.
So, Dr. Browne, can you tell me just a little bit in general about your work in ophthalmology, maybe the things that you specialize in, and maybe what makes it interesting?
Sure. Yeah. So I function within a subspecialty of ophthalmology called vitreoretinal surgery and medical retina. So I spend some of my time doing surgery and some of my time taking care of people with medical retinal diseases.
Mhm.
And the thing that drew me to ophthalmology was the variety of ways that you can improve someone's living experience by restoring and preserving their vision. Um, uh, in parallel with that was the interest that I had in the biology of the eye and how it converts light into an electrical signal that allows us to perceive the world. And so in those two things put together was a good platform for me to kind of think about how to work as somebody who has an interest in technology in medicine. And so in ophthalmology, it's a heavily imaging intensive field, almost as much so as radiology is looking at the human. Ophthalmology, you're looking at the eye, you're taking photographs of the eye with a variety of different technologies. And so I thought that was a good playground for my technical interests as well as my medical interests in helping improve people's quality of life.
That's fantastic. And we'll get into the imaging in just a moment. If you could maybe elaborate a little bit more on exactly some of the procedures that you do on a regular basis and what those are dealing with specifically.
Yeah, so in clinic, I'm not actually 100% sure if this is true or not, but I think that the intraocular injection may be the most commonly performed procedure of all medical procedures that exist.
Wow.
Because there are people who have diabetic retinopathy, people who have strokes in their eyes, people who have age-related macular degeneration, all with huge disease burdens in the developed and developing world that benefit nowadays from these medications, which have been in widespread use for 10 to 15 years about, and they actually are sight restoring and preserving. So the ability to take someone who has poor vision because of any number of diagnoses, inject a medication into the eye and restore their vision, or at least preserve it, is very powerful. And people will undergo these procedures very willingly because sight is so important to them, and I think rightfully so. The other procedures that we'll do in clinic, other than intraocular injections, we have a variety of laser-based procedures that are used to either burn tissue or break up tissue inside the eye. And so people who have diabetic retinopathy or strokes in the eye, people who are having complications from these diseases that affect the blood flow in the eye. Historically, this is the therapy that was used, but nowadays it's not used as much because of injections, but we generally burn the retina with a laser that causes a focal area of burning. We also have other types of lasers that can be used to break apart scar tissue inside the eye, or make small pathways for fluids to move through the eye freely. So these are kind of the general procedures that are performed in clinic on a regular basis. There are some other more subspecialized procedures that might be performed in more unique circumstances. Surgically, the most commonly performed surgery in the world is cataract surgery, which I don't practice, but at least 8 or 9 of our colleagues in our department are cataract surgeons. I do cataract surgery periodically, but it's not something that I practice. But every ophthalmologist is trained to perform cataract surgery as part of the residency training. So the types of surgeries that I do are repairing retinal detachments. So the retina is the light-sensitive tissue inside the eye. If it starts to separate from the wall of the eye like wallpaper peeling off, then we'll enter the eye or use a variety of tools around the eye to try and restore the normal anatomy of the retina. Sometimes there can be scar tissue that forms in the retina that we'll have to go inside the eye to remove the scar tissue so that the retina can function normally. Sometimes holes develop in the retina and in the central vision, and we try to resolve the hole in the retina. So actually I'm doing a surgery like that tomorrow. So a variety of procedures, of course, we can do surgeries where we try to fixate lenses inside the eye, suspend them from the wall of the eye when someone has had major trauma that doesn't allow normal cataract surgery type procedures to suspend the lens inside the eye.
That's fascinating. Because there's so many different ways in which technology is like relevant to the treatments that you do. I want to go back for just a second and focus on the intraocular injection because that's the one that we filmed.
Mhm.
Can you talk a little bit about the disease states that necessitate, introducing the drugs in that method?
Yeah. So generally speaking, there are diseases that are vascular in nature or inflammatory in nature that benefit from injections inside the eye. The most common diseases that benefit from these injections are diabetic retinopathy, retinal vein occlusion, and age-related macular degeneration. In diabetes or diabetic retinopathy and retinal vein occlusion, there is loss of normal blood flow into the eye. And so the eye starves for oxygen. The blood vessels don't function normally. They can leak because of inflammatory processes that cause them to leak. And new blood vessels can begin to grow that can bleed, form scars, and the scars can also contract and cause retinal detachments. The most common and commonly injected medications are intended to stop those new blood vessels from growing and preventing blood vessels from leaking. In the aging population, with the baby boomers coming into the geriatric age group now, there's an expanded population of people with age-related macular degeneration. And this is the most common cause of permanent blindness in people in the elderly. And so in this disease, the cells that support the retina, that form the foundation of the retina, die. And the foundation underneath those cells also can become disrupted. So new blood vessels can begin to grow underneath the retina and underneath the foundation. And those blood vessels can leak and bleed. And that leaking and bleeding can cause vision loss. So we inject medications to combat those new blood vessels. There's also diseases that are inflammatory in nature, autoimmune diseases, in which case there's inflammation inside the eye, and we'll inject steroids inside the eye for that condition as well. So in each case, we're introducing a small volume of fluid, 50 microliters, or a small pellet which is basically an implant that releases medication over time. And we do it through a small incision using a needle in the white part of the eye, about 4 millimeters away from the edge of the white part of the eye and the cornea, which is basically the edge of the brown of your eye in this example, and the white of your eye. So we go 4 millimeters into the white part, and we put a needle into that part of the eye. Of course, putting a needle into the eye is very painful, so we anesthetize the eye beforehand using local anesthetics. Those can be in drop form and gel form, and injections underneath the retina. Not underneath the retina, my apologies, underneath the conjunctiva, the skin that covers the white part of the eye. And that helps to achieve anesthesia before injecting medication into the eye itself.
So you use the same technique then to address a variety of different disease states. And I'm wondering, when you talked a little bit about the details of exactly how you perform this procedure, does it change at all from, if you're treating one kind of retinopathy to another?
The procedure is largely preserved. I mean, everybody who does this procedure, which is usually retina specialists, they have their own, unique twist or flair or flavor for how they do the procedure. But in general, we're all putting a needle into just about the same location in the eye to introduce something inside the eye. And we might have some differences in how we anesthetize the eye, how we sterilize the eye, how we keep the eye open, that sort of thing.
Okay, for sure. So when it comes to actually performing this, and I know it's very routine, and like you said, it may potentially be the most common procedure sort of that's done. I take it that it's a very effective and efficient procedure to perform, but I'm wondering if there are any, pain points, places where you can obviously do it better, or anything that maybe you just think could be done differently as far as these injections are concerned?
I mean, the way that I do it, I've tried to streamline the flow for the patient and for myself, because so anybody who's requiring these injections on a routine basis, it's incredibly disruptive to their life. If they're having to come in every single month to get an injection in their eye, and if they have to get an injection in both eyes, that's a larger burden. If it's an elderly person, they're usually coming in with someone who's younger than them, who's taking time off work to bring them in. And the reality is it also takes significant time to perform the procedure in the clinical setting. So there's only so many doctors that are available to do these injections, and so there's a strain on the resources, not only from the patient's side but also from the healthcare system side. So whenever I do these procedures, I try to make sure that from start to finish of the procedure, it's less than 5 minutes for the patient, without them having to move around too much. That they just get the procedure and then they can get home as soon as possible. Of course, they do have to have an evaluation before the determination is made for the injection in most instances. But exactly right. What I've done is try to minimize the time that it takes to perform the procedure, not only for the patient but also for myself. So
Got it.
not everybody does the procedure the same way. So, and if you get a room of retina specialists together, everyone will think that they do it right, just like I think I do it right. And other people will say, no, I don't do it right. And there's only so much that you can do to get people to agree. But I think I'd be hard pressed to find someone who has patients who have less pain and spend less time in the process of getting their injections than you can in my clinic. And I'd be happy to go head to head with anybody on that.
Right.
And also doing it safely. Of course, it's not worth doing a procedure unless it's being done safely. So, in terms of recording these types of procedures, the procedure that you recorded with me doing it is something that I think is appropriate for a retina specialist, someone who does a lot of injections, to do it this way. And you have to be comfortable doing it this way. I don't recommend someone who's learning the procedure to do it the same way necessarily, because they need to, for example, hold the eye open with an instrument so they don't have to worry about the eye closing during the procedure. At this point in my career, I've gotten to a comfort level where I know that I can keep the eye open and not have to worry about that sort of thing. So, whenever you're training people, there's like the beginning level training, which is appropriate, which is what I did when I was a resident and what I expect of my residents. There's the fellow level of training, which is kind of, okay, now I need to start thinking about how to do this more efficiently and improving your technique. And then there's the attending level training, where we all have ways that we can improve and doing the way that we perform procedures. And so, in my case, I think this is one procedure that I've gotten to a point where I don't know. I would be curious if anybody has suggestions that might make it better. But I've kind of taken an engineering approach to how I do this, to try to minimize the time it takes to do the procedure.
Yeah, so let's talk about that for a second. You talked about holding open the eye, for example, right? And that's something it's a technique that you employ. Do you think that that's something that maybe would be a useful, if an engineer out there were to design a way to hold open the eye, while you're performing the procedure, would that alleviate a lot of the difficulty in performing the injection?
Yeah, so people have developed tools to hold open the eye in this example. And so I just don't use that tool anymore.
Got it. Okay.
Just because it is time consuming. Patients have been shown in research reports that they do not like the instrument.
Okay.
And so I just don't use it because I can comfortably do it with the tool that I use to sterilize the eye. So I use the tool that I sterilize the eye to also hold the eye open. And it's adequate, more than adequate, actually. There are other elements. I mean, people have been tried to develop additional tools that you put onto a syringe to stabilize the eye and control where you inject the medication. Can have value, but it also is yet another expense. It's more waste, and I think it probably is not necessarily adding the necessary ease and convenience for both the patient and the person performing the procedure.
Yeah. I mean, it does sound like with taking, no longer than 5 minutes, that it is a very well streamlined, especially someone like yourself who's very practiced at this. It's a pretty straightforward process. I think, these are, like you said, very common. So you maybe go through a handful of them, every day that you're operating. So finding out, I think, where the things can be improved might prove to be a little bit more marginal in something like a injection than maybe some of your other procedures that you do. So I wanted to ask now, maybe this will be our final question before I let you go, is when we talk about, the confluence of engineering and taking engineering approach to ophthalmology, what do you think are some of the more promising technologies or one of the pressing issues that need to be addressed, as soon as possible?
Yeah, I think, there's a variety of different things. I think some of the technologies that we've developed are an impediment to efficiency and providing world-class care. I think that in general in healthcare, the biggest impediment that exists is the electronic medical record in its current form, and especially the one that's most common and has got its greatest foothold in the country, which is Epic. It was designed for billing purposes, and it's designed, they'll make the argument that it's designed for clinicians, but there's no part of its workflow that actually makes sense. So it's actually an impediment to all parts of medicine, because it doesn't use, I mean, we put people on the moon, and it would blow your mind if you saw how clinicians have to spend their time typing into the chart the way that we do. It would just blow your mind. There are websites that are just leagues and bounds more sophisticated. And that's all this is this human computer interface. Not even brain computer interface, it's human computer interface. And that's how we do everything now. Everything is through a computer for documentation, which we have to do. We have to know what we're doing with our patients, and what is working, what's not working. We have to have a way of organizing that information. But in terms of building and the billing components and the kind of the industrial engineering workflow components, that's one of the biggest impediments in all of medicine. In terms of ophthalmology, the areas for kind of greatest improvement are those that take away the need to subjectively evaluate a person's visual function, so objective visual function testing. And there are companies out there that are developing these tools that streamline how we quantify what people can see, without them having to take a multiple choice test, for example. And then finally, also, when we examine the eye, the imaging tools that are available are have increasing scope of field of view and resolution. So, eventually we will be able to garner information about the whole visual pathway functionally, as well as the whole visual pathway structurally, and correlate them together. But there's a lot of room for kind of developing these integrated tools in ophthalmology. And in surgery, there's, it's access, it's controlled workflow. It's a limited resource. How do we manage the resource? And how do we make that resource available always and quickly and easily? Because I can't tell you how much time is lost by doctors, and really most of the time it's the training doctors, the doctors in training. Even in their final stages of training, they're just wasting countless hours waiting to be able to do something for their patients. For example, get them into the surgical suite. So there's limited resource there. Managing that resource kind of effectively and intelligently. These are all problems that engineers around the world are trying to solve. And the trouble is when you have a medical center that tries to use a generic solution, one size fits all. It's things have to be adapted to the environment they work in. Just like certain vaccines need to be frozen. Frozen ones probably aren't going to be the best generic solution in sub-Saharan Africa, for example. You need to have something you need to have something that works uniquely to different environments.
Definitely. Wow, so very comprehensive, but I think if I understand this correctly, like the biggest issue is really just like making or increasing the availability and the speed of workflow to provide access to as many people as possible, which makes perfect sense given that retinopathy and intraocular injections are so common that being able to do more of those more frequently and more widely makes a big difference.
Exactly right. Yeah, that's all of medicine. How can someone get in to see the doctor without having to call and talk to a call center, then talk to a scheduler, then talk to it's kind of nuts.
Yeah,
Anyway,
definitely. Um, well, Dr. Browne, thank you so much for taking the time to do this interview with me. I'm going to go ahead and hit pause or stop the recording.